Good evening. I'm Kelly Gare-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. A Women's Journey strives to improve your well-being through health education. Tonight's speaker, Dr. Erin Michos, serves on several committees of the American Heart Association and presented her research at the recent AAH meeting. In these capacities, Dr. Michos will feature several new research findings about heart disease and supplements that were among the research presented at the 2020 American Heart Association meeting. I am pleased to introduce our speaker, Dr. Erin Michos, Associate Professor of Medicine, Director of Women's Cardiovascular Center, Associate Director of the Ciccone Center for the Prevention of Heart Disease, and a member of the A Women's Journey Faculty Committee. Following our conversation, Dr. Michos will respond to many of your questions, so please use the Q&A box next to the video. Tonight's webcast will conclude at 8 p.m., and tomorrow you'll receive an email asking you to complete a brief survey about this webcast. In the coming days, a video of tonight's live streams will be available on the A Women's Journey website, hopkinsmedicine.org/A Women's Journey, under Conversations That Matter. I want to take this opportunity to also invite you to join us for a very special and important program, COVID-19, 1 year later, from 7:30 to 9 p.m. on Wednesday, February 3rd. 3 Johns Hopkins experts will discuss the current status of COVID, including new mutations, the unique features and safety of the approved vaccines, and lingering effects among COVID survivors. Just visit our website, hopkinsmedicine.org/A Women's Journey, to learn more and to register. And now I'm pleased to begin tonight's conversation with Dr. Michos. Dr. Michos?
Thank you. Thank you so much to have me here tonight to talk with you about finding studies that was presented at the recent American Heart Association Scientific Sessions that was held in November 2020. So one of the hot topics that was discussed, of which there were 3 major clinical trials presented, was related to supplement use and whether they can prevent cardiovascular disease. And this is a hot topic because approximately half of the United States adults, 1 out of 2 adults, report using at least one kind of supplement. And the greatest use of supplements tends to be among older college-educated women, which tends to be a demographic that's actually probably at least risk for a nutritional deficiency. Now, people lament big pharma, but I want to mention that there's the big supplement industry. Americans spend $21 billion every year on supplements, and globally almost $300 billion. And so the question is whether these supplements actually confer any real meaningful health benefits. So one of the studies that was presented at the American Heart Association meeting was called the Vital Rhythm Trial, and it was looking at whether fish oil supplements, omega-3s, again, this is supplements, not food, and vitamin D supplements, whether they can prevent atrial fibrillation, a very common heart rhythm. So atrial fibrillation is very common heart rhythm disturbance. It's thought to affect 33 million people worldwide. So you likely may know someone who has atrial fibrillation. And it results in significant symptoms that can reduce someone's quality of life. And patients with atrial fibrillation have increased morbidity. They're at increased risk for stroke, heart failure, heart attacks, dementia, and even death. And so that's why it's really important to try to prevent AFib, because our current treatment options that we're using tend to be employed late in the disease process after people already have developed AFib. They sort of have limited long-term success. And so there's really a pressing need to find therapies that can prevent the development of AFib in the first place. Now, supplements have appeal as a potential therapy for preventing AFib because of their relative ease, their widespread use and availability, and particularly omega-3 fatty acids, fish oil, and vitamin D were ones that thought they might have potential for benefit. They might have potential electrical properties, and individuals who have at least low levels of these nutrients in their blood are at greater risk for AFib. So that was why it was worth investigating. Now, the Vital Rhythm trial was actually a subset of a much larger trial that was initially presented a couple of years ago called the Vital trial. So the VITAL trial enrolled over 25,000 initially healthy men and women that didn't have cancer or heart disease at the beginning of the study over the age of 50. And it was something called a factorial design, which means in this trial, they were actually simultaneously studying two different supplements. They were comparing vitamin D at 2,000 international units versus a placebo, and they were also comparing fish oil, which this preparation was an EPA plus DHA at 1 gram a day versus placebo. And the participants were followed for about 5 years. And the main study was investigating these supplements for whether they could reduce cancer or cardiovascular disease in terms of heart attacks, strokes, and cardiovascular death. And these results were already presented, and there was no benefit for the supplements for these outcomes. But the Vital Rhythm wanted to know, well, can these supplements prevent atrial fibrillation specifically? So unfortunately, the bottom line is that they did not. And so here are these results. This is the results for fish oil, the EPA DHA. So what the slide is showing is this is the years over the study, the 6 years of follow-up. And this is the incidence, the number of the people, the rate of people developing AFib. And you can see that cases of AFib increased over time. But essentially, there wasn't any difference between the number of cases in the placebo arm in the orange versus the number of cases in the individuals who were randomized to the fish oil arm. And actually, if you see, there's actually maybe were a few more cases. The blue line's a little bit higher, although it wasn't significant, with more AFib in the fish oil arm. So the fish oil did not prevent atrial fibrillation, and neither did vitamin D, same kind of supplement set up with a number of cases of AFib. And essentially the blue and orange lines are on top of each other, meaning the rate of atrial fibrillation was identical in both arms. So, in conclusion of this study is that supplementation with EPA and DHA around 1 gram a day or 2,000 international units of vitamin D did not reduce the risk of atrial fibrillation over 5 years and really doesn't support the benefit or the use of these supplements for this purpose. And again, as I mentioned, they were already shown not to also prevent cancer or heart disease either. So we're still lacking therapies that can help prevent AFib, but I just want to emphasize that we do know that following a healthy lifestyle, eating healthy, exercising, maintaining a normal body weight, all of these things can help prevent AFib through a healthy lifestyle, but supplements may not be the answer. Now, again, as I mentioned, there's been tremendous interest in fish oil. A lot of patients, take fish oil to try to prevent heart disease. And so there has been some interest in whether it can benefit other populations. And the reason why there's interest in fish oil is, there have purported benefits, thinking that maybe fish oil can reduce inflammation, maybe fish oil can reduce blood clotting, and that might offer cardiovascular protection. So one of the another studies that was presented also at the American Heart Association meeting was the MEMI trial. And this was looking also at fish oil supplements, but in a different population. They were looking at older adults who had a recent heart attack. A myocardial infarction is the other name for heart attack. And this was looking at 1.8 grams a day of polyunsaturated fatty acid. So this was a combination of EPA and DHA, a little higher dose, 1.8. And I want to mention, because this come up, is that the comparator, the control, the placebo, it wasn't a sugar pill. It's essentially a corn oil pill. And this is because fish oil is oily. And in trials, we want to blind the participants so that they don't know which arm that they're in. We want to, keep it a secret so they don't know what they're taking. And so we wanted to try to make the control group, the placebo, kind of look just like the treatment arm so that patients can't tell what they were doing. So we're comparing a fish oil with a corn oil. And that becomes important later because another study used a different type of oil. But in this trial, it was older adults over the age of 70 who had a heart attack 2 to 8 weeks prior, so a recent heart attack. And participants were randomized either taking the fish oil or the corn oil in a randomized fashion. There was about 1,000 older adults. And the main outcome was cardiovascular disease, but they also looked at AFib in this trial. And unfortunately, similar to the other trials, there was no benefit of cardiovascular events. If you look at the two arms, again, this is the percent of patients that had an event over the time of the trial. And the red arm of the supplement is virtually on top of the blue arm, the placebo, meaning there was no difference in the two groups. It was not statistically significant. Now, what about atrial fibrillation? Well, again, unlike trend for benefit, we see a possible signal for harm. There was an 84% increased rate of AFib. Now, granted, the event rate's pretty low. You can see the numbers are pretty small. So it wasn't a lot of patients that developed AFib, but there was a bit more AFib in the fish oil arm than the placebo. So instead of a benefit, it didn't quite meet statistical significance, but there was a little bit of a concerning signal that there might be more AFib. So the conclusion of this trial is, again, that fish oil supplements, and again, we're not testing diet, we're talking about supplements, they did not reduce cardiovascular events or death in older patients who had a recent heart attack, and potential harm in causing more AFib events couldn't be ruled out. So a lot of times patients think supplements are benign because you get them over the counter, but they may not be entirely free without risk themselves. Now, what about prescription fish oils? This comes up a lot because there was another trial I'm going to mention over a year ago that showed benefit. And so the STRENGTH trial was also presented at the American Heart Association meeting in November, looking at a different prescription fish oil. This prescription fish oil was a 4 grams a day, so a very high dose of DHA plus EPA. So this the trade name is Epanova, but this is again a combination EPA and DHA. So this population enrolled about 13,000 adults who were at high cardiovascular risk. These were adults who had high triglyceride levels, low HDL levels. They all were on statins, so it's testing the benefit of this prescription fish oil on top of already taking statins. And these were patients who were at elevated risk for cardiovascular disease. And this was a big trial. It was in 22 countries around the world. And again, compared this prescription fish oil with a corn oil comparator. As I mentioned, they like to compare a placebo group that looks very similar to the treatment group. And they were looking at whether this prescription fish oil on top of a statin can prevent cardiovascular events. And what did they find? Well, again, this is time on this axis. This is the percent of events with events. And these arms are literally superimposed on top of each other. Between the fish oil and the corn oil, there was no benefit at all seen at all in this trial. So, they tried to tease this out a little bit because there was a mixture of patients in this trial. There were some that had already had a heart attack or stroke, which we call secondary prevention. And there were some that were at risk, but hadn't had a heart attack yet. They were trying to prevent their first heart attack. But, even in these two different groups of patients, there was still no benefit of the prescription fish oil. So in summary, for this trial, in patients already treated with statins who had high cardiovascular risk with high triglycerides, giving this 4-gram combination of EPA, DHA didn't reduce the rate of subsequent cardiovascular events over 3 years. And this is different than this prior trial, which I'm going to mention next, which studied a prescription fish oil that was purely EPA. And then again, this was the combination of EPA plus DHA. Furthermore, AFib, I should have mentioned, was also higher in strength as it was in OMEMI. And so this actually is concerning that we keep seeing this signal of more AFib instead of less with omega-3. And so this casts some uncertainty about whether there's a net benefit or actual harm with omega-3 supplements. Now, the trial I keep mentioning, the one that got a lot of press and interest was one that presented 2 years ago, looking at a different type of fish oil. A prescription icosapent ethyl is a very purified form of only a pure EPA, so no DHA in this. And in high-risk patients with high triglycerides who were on a statin, this particular formulation actually did reduce events. There was more events in the placebo arm and fewer events in this fish oil arm, with a 25% reduction in major cardiovascular events. And so this created a lot of excitement. So we're treating patients now who are at high risk with this prescription fish oil. But then it was very disappointing that that other fish oil didn't show a benefit. And so this led to a lot of us puzzling. And I really think that the type of fish oil matters. But I certainly think that what we do know for sure is it seems like the dietary supplements that you get over the counter are not good. This is a study that pulled some of the dietary supplements over the counter and looked at the mixture of different fats in them on the chemical composition. And, the polyunsaturated fats, the good ones we think are the EPA and DHA, and that only made up 30% of the supplements. The other supplements were contaminated more than a third with saturated fats. And those are the bad fats that raise LDL. Furthermore, the kind of dietary supplements are very purely refined, and they can be very oxidized. They can contain contaminants like PCBs. And it's very difficult to get those high levels of 4 grams, with over-the-counter dietary supplements. And this just shows you the example of this is the prescription fish oil. See, it's liquid at room temperature. Think of vegetable oils, olive oil, corn oil, vegetable oils should be liquid at room temperature, where saturated fats like butter and coconut oil are solid at room temperature. And the dietary supplements were solid at room temperature, suggesting, again, they had too much saturated fats in them. So I don't recommend dietary supplements. In terms of prescription supplements, we have one trial showing benefit and one trial not showing benefit. It's a little confusing, but I think the main message is that polyunsaturated fatty acids, fish oils, are not all the same, that the type matters, the dose matters. And I should mention in the other trial, look, the benefit was seen the more one raised their blood levels, EPA. So, whether you achieve adequate blood levels, EPA probably matter. So that was about supplements. So 3 major trials there at AHA. Now this trial that I'm going to share next, I think is probably one of the most interesting ones and probably relevant to at least my clinical practice, is the issue with statin-associated muscle symptoms. Lots of patients report muscle aches on statins. And the question is whether this is a real effect or whether this is something what we call a nocebo effect. And this next trial, the Samson trial, investigates this. And just to explain what a nocebo is, you probably heard of what a placebo effect is. When people are taking something, often they feel better because they think they're taking something, so they think it's working, so they feel better on the placebo effect, even though it might just be a sugar pill. Well, the nocebo effect is the opposite. So if you think something's going to harm you, if you have this mental framework that you're going to get side effects, you think something's going to harm you, then you're more likely to attribute everything to that. And so that might be what's going on with statins. And that's because of all the sort of negative press about it. So that's what this study looked at. But at first I want to emphasize why this is such an important issue that appropriate patients take statins, is because statins meaningfully, they're one of our, they're our first line therapy for prevention of primary and secondary prevention of heart disease, because there's overwhelming data from numerous clinical trials, hundreds of thousands of patients that show that they reduce risk of events. So here's some of these trials on this slide. So secondary prevention are patients that already have heart disease, and primary prevention are people at risk. And these are different trial names. And we see as the LDL cholesterol goes down, if we can lower LDL cholesterol on the statins, we can reduce the number of patients who have an event. And putting all these trials together, statins reduce the risk of heart attacks by about 30%, and they reduce death by about 10%. So they have meaningful benefits. That's why we keep trying to get patients on them. But statin adherence is one of the main challenges we see in clinical practice. And patients become non-adherent over time. And this is just one study from Kaiser that looked at prescription refills. And among patients who were given a statin prescription for an indication, 12% of them never filled it. Another 12% filled it but never started it. And another 29% never finished the course. So at 1 year, only 47%, less than half of people who were given a prescription were actually still taking the statin at 1 year. So given all this meaningful benefit, a lot of people who are not taking it, so they're not achieving the benefit. So the concern a lot of people report is muscle aches, which is confusing because in clinical trials, when people are blinded and they don't know what they're taking, there's actually no difference in muscle aches between statins and placebos. And so this is a bunch of statin trials. And this looked at the proportion of people who had to stop the study drug. They had to withdraw due to side effects. And there was no difference in who had to withdraw in the placebo arm versus the statin arm, meaning that more people didn't have to stop the statin when they didn't know what they were taking. But despite the fact that muscle aches are not more common in trials, in real world practice, somewhere up to 20 to 30% of patients report having muscle symptoms. So this brings us back to SAMPSON, the trial that was presented at the American Heart Association meeting. And again, I think this is a really interesting design because it's called an N of 1 trial, meaning that patients were their own control. So instead of comparing two groups, people were compared within themselves. So let me walk you through this design. It ultimately enrolled 60 patients. So this was a 1-year trial, and individuals were given 12 bottles of things, and they changed a bottle every month. So every month they changed. So 4 of the bottles had statin in them. 4 of the bottles had an identical match placebo that looked identical in appearance to the statin, and 4 bottles were empty. So on that month, if somebody opened the bottle and it was empty, so they took nothing that month. So they either took nothing, or they took a placebo, or they took a statin, and they alternated a bottle every month. And then during this time, they recorded the amount of symptoms, the muscle symptoms they had. And the goal of the trial was to measure the burden of symptoms, how much side effects they were having, and how many people were still on their statin 6 months after the trial was over. So walking you through a little bit about an example for one patient where you can see what this means. So the no treatment, when people weren't taking anything and they knew they weren't taking anything for those 4 months, this is the amount of side effects that they would have, the baseline side effects. And then these are the side effects that they had when they're on the placebo versus the statin. So the difference between the white bars and the pink bars, indicated here by the black, this is the nocebo effect, because there's really no difference between placebo and nothing, but except that they're taking a pill every day. So just the act of taking a pill every day, this is the difference in symptoms from taking a pill. Now, any difference related to statins itself would be the difference between the red and the pink, which would be the pharmacological effect. So what did they find? Well, putting all the patients together, 8% of patients had muscle symptoms when they were taking nothing, an empty bottle, taking nothing, they had 8% symptoms. Now, when they were taking a pill, 15 to 16% of people had symptoms. So there was an increase in symptoms from taking nothing to taking a pill. But there was no difference really between the statin and the placebo, a small 10% difference, meaning that 90% of these muscle symptoms was related to the nocebo effect, just the act of taking a pill from going from no treatment to placebo. So what the investigators did next is that they shared these patients are compared to themselves. This is their own control. So when they shared the data back with the patients and said, look, you had just as many symptoms when you were on placebo as when you were on statins. And when they shared this with patients and discussed this issue, actually, they were able to get half the patients back on their statins. So half the patients were still taking the statin 6 months later among those who had stopped. So hopefully what the study showed, which I think is really interesting, is that patients really do get side effects from statin tablets. They reported side effects, but 90% of their symptoms could also be elicited by a sugar placebo. And in this N of 1 trial, compared to periods of no tablets, when this information was revealed back to patients, we were able to get 50% of the patients to restart their statins. And so in summary, side effects of statin tablets are majority of it's caused by the simple act of taking a pill itself. People don't like taking a pill. They feel sick when they're taking a pill, and the act of taking a pill is causing side effects, not really what's in it. It's not the statin, it's the pill. So I thought that was a very interesting study. All right, so some other things are presented at the HA, influenza vaccine, and this is still a hot topic, even though we're now in the midst of COVID vaccine dissemination, but influenza certainly is a major cause of death every winter before the COVID pandemic. So we performed, this is one of my studies I presented, I performed a meta-analysis looking at the influenza vaccine on the risk of death and cardiovascular outcomes in patients who had heart disease. And so meta-analysis means that we pooled studies together to look at the results when we combine a large data together. So we pooled 16 total studies together that had over 200,000 patients. And influenza vaccine compared to a placebo or usual control actually reduced death. So there was less deaths in patients who got influenza vaccine. Not only did it reduce any death, 25%, but it actually had an 18% death reduction from cardiovascular disease. So we're not just preventing deaths from the pneumonia, we're preventing deaths from heart disease in patients who were at high risk, who already had heart disease. And this was because there was a 13% reduction in heart attacks and strokes, and that was likely why there was less death. So in summary, influenza vaccine reduced major adverse cardiovascular events, including heart attacks and strokes. It reduces death from cardiovascular disease and mortality. So this is really important outcomes, especially in the context that nearly half of individuals are not getting their routine influenza vaccine in the United States. And our study reiterates there's a survival advantage there, and not only is there advantage for, preventing the flu, but by preventing the flu, we can actually prevent heart attacks and deaths, because flu, we know, can actually trigger a heart attack. And so we hope that our studies can help strengthen healthcare professionals and policymakers to advocate influenza vaccine as important therapy for preventing cardiovascular outcomes. And I think this is going to be similar for COVID vaccine too, because we know that viral infections can trigger heart attacks. So if we can prevent viral infections, we can prevent heart events too. All right, so another topic near and dear, as I mentioned, the HA meeting was packed with stuff. This is another one of my studies, but mental health is really important, and probably even more so during this COVID era. And this was one of our studies that looked at mental health disorders in patients who are presenting with an acute heart attack in the United States. And we used a national database of inpatients across hospitals across the country who were admitted with a heart attack. In fact, from 2008, 2017, we looked at the data for 6 million hospitalizations for heart attack. And what we wanted to know is, what is the burden of mental health disorders among these individuals who are developing who presented with a heart attack over time? And so what we saw is that there's an increasing trend, particularly depression here in the yellow and anxiety over the red, that these are really going up over time. There was also a slight increased risk in bipolar as well. So there's increasing prevalence of mental health disorders among patients with acute heart attacks. And also, one of the things we found in the study was a little bit worrisome is patients with mental health disorders, particularly depression, bipolar, schizophrenia, they were less likely to get guideline-directed care, like they were less likely to get cardiac cath and coronary vascularization, stents and bypass. So patients with mental health disorders who present with a heart attack also are being undertreated, which is worrisome. We also saw that there was differences by sex and by race in these trends. For example, women suffer from depression and anxiety more than twice than men do. Across all race ethnicities, mental health got worse. But for depression, Native Americans had the largest increase, and PTSD was the highest among Native Americans and among Blacks. So our conclusion of our study that we presented at the HA was that we really need to focus on mental health interventions, that the mind and heart and body are all very interconnected, and we need to improve mental health to improve cardiovascular health, and that we need to screen for mental health disorders along with screening for traditional risk factors. And while many cardiologists like myself might not be equipped to maybe treat mental health disorders, if we don't look for it, we won't know it's there. And we at least can do some quick screens so that we can get our patients who've been identified to have a potential problem, get them the care they need through a team-based approach by referring them to the appropriate care providers who can perhaps deliver psychological interventions. And then for my last topic, I'm going to talk about AHA goals about health equity. So the American Heart Association at the start of the decade and beginning of 2020 set goals for 2030 impact goal, what they want to work on over this next decade. And the biggest thing they mentioned was focusing on health equity. So importantly, if you look at trends of what's happening with cardiovascular disease in the United States, we're losing ground again. You know, for many decades, we actually had good progress here, women in the red, where we were reducing cardiovascular death, although there's still more deaths compared to men, but we were reducing cardiovascular death in women, making progress until about 2013, where we've stopped reducing cardiovascular death. It's plateaued. And actually, there's an uptick. So cardiovascular deaths are going back up, both in men and women. And particularly middle-aged women, 45 to 64, the heart disease rates are accelerating the most in this group. They've increased 7% since 2017. So they really want to focus on health-adjusted life expectancy, healthy life years. So not only getting people to live longer, but living longer free of comorbidities, healthier lives. And by 2030, they want to improve that in the United States from 66 to 68 years and from 64 to 67 globally. And they set additional targets for health equity in populations, as well as improving mental well-being. As I mentioned, mental health is really important on top of physical cardiovascular health. So last year, the AHA released 2 scientific statements about some high-risk populations that need some more attention. One of the statements was on the pregnant woman. So we know that maternal mortality in the United States is terrible. We are worse than any developed countries. And the leading cause of maternal mortality is cardiovascular disease. These women predominantly are dying of cardiovascular disease. And so this guideline highlights this and talks about the importance of the 4th trimester, particularly for women who've had a high-risk pregnancy with preeclampsia, making sure they get plugged in with cardiology and other specialties after delivery, that we don't neglect to take care of the mother after delivery. And I was pleased to be able to write one of the commentaries for the American Heart Association on this statement, which is available online. And the AHA also released a separate statement addressing cardiovascular health in the LGBTQ community, another neglected population that needs more attention on their prevention. And I also wrote a commentary for the AHA about the urgent call of action of improving the cardiovascular health in this community. So we're losing ground in awareness of women that heart disease is the leading cause of death of women. So the American Heart Association has sent out surveys to women patients over the years, asking them what the leading cause of death is. And we're losing awareness. From 2009, we went from 65% of women who knew that heart disease was the leading cause of death in women to only 44%. So women are less aware. Women are more likely to attribute the leading cause of death to cancer. And the lack of awareness was particularly worse among Hispanics and Black women, and also among younger women, where potentially you could do the most for primary prevention. So we need to double down on our efforts to get the message out. And for my very last few minutes, I want to talk about a topic near and dear to my heart about improving representation of women patients in cardiovascular clinical trials and why that's so important. Now, when we do a trial, we're doing the trial because we don't know for sure if a drug or a device is efficacious, and that's why we're studying it. So although there may not be direct benefit in terms of that drug for a woman participating in the trial, there are lots of other benefits for women participating in a trial. So just being in a trial participants have a better access to the gold standard of care, because they're being seen a lot by clinicians and investigators, so they have more access to innovative treatment and care. But really importantly is they're generating knowledge that's going to help future generations of women. We won't know if something's efficacious or safe in women unless women are in trials to study this. So why is this so important? Well, this is highlighted by this data that's from the late 90s, but it looked at a bunch of drugs that were on the market. These were drugs that were already out there, given to patients on the market that had to be pulled off the market due to safety concerns. Well, of these drugs, fen-phen and some other ones are on here. You won't get these anymore again because they're pulled off the market. But of these drugs, 80% of these drugs had a greater safety risk in women than in men. So they were more unsafe in women. And so if we have more women in the clinical trials, before these drugs get on the market, we would understand more about safety data and have safer drugs. So women, continually be underrepresented in cardiovascular clinical trials. I didn't have time to share all this data. I had 2 studies last year where I looked at lipid lowering trials and I looked at cardiometabolic drugs like diabetes drugs, all those trials, and women were underrepresented. Usually less than a third of patients in the trials were women. And this really has important implications about whether the drugs are efficacious and safe, and whether the results can be even generalizable to women we take care of in practice. And so we really need improved enrollment of women in trials. And so one of the talks I gave at AHA is how to do this, how can we increase women in trials? One of my main suggestions, of course, is to actually get women patients involved in the design of the trial. That not just having this being designed by the clinician investigators, but have patients on the study team to help design and conduct the studies, because patients will help identify barriers that the clinicians may not think of. We want to also diversify study team and investigators. I'll show you that on my next slide, that women and other minorities are more likely to enroll in trials if the study investigators look more like them. We want to make sure there's not too many restrictions, that women who can qualify, and then we approach women for enrollment. And we want to dispel misconceptions. So women patients tend to overestimate risk and underestimate benefit. And so we want to do better with educating. Patients are highly monitored in trials, so their safety is watched very closely in trials. We need to make trials easier to participate in women, things more flexible. It's very hard for women who hold on jobs and are caretakers of children or other members of their family to come in to all these study visits. And we've done better with this during COVID, coming up with novel ideas. But study visits perhaps can be on weekends or by phone or online or through primary care doctors to kind of minimize the burden of study visits and trying to avoid hidden costs. So usually during a trial, we cover the drug and the device is covered by the trial, but there can be other expenses such as transportation to the study visits or time off work. So we need to avoid those costs, because people giving up their time for trials shouldn't have to pay any of their own money to participate. For women that were approached but declined, try to understand, why did they not want to participate in the trial? What was the barriers or concerns? Because maybe we can overcome them. And one thing that I think really we should do more of is, after the trial is done, is engaging the women who are in the trial to be the spokesperson to disseminate the results out to the population. But unfortunately, there's a dearth of women in clinical trials in terms of investigators. This is one of my studies where I looked actually at the pipeline of cardiologists, of cardiology fellowship training, looking, and we showed that among cardiology fellows, individuals being trained to be a cardiologist, only 21% were women here in the orange bars. And so fewer women are training in cardiology compared to any other medicine specialty. So we're not, we're losing a lot of talent pool of women are not entering cardiology as a profession. And if you look at clinical trial leadership, so of these trials that were published in major journals over a 4-year period, only 10% of these trials were led by a woman investigator. And what's shocking is more than half of these cardiovascular trials had no women investigators in the trial steering committee. And, it matters. There's correlations that have been shown that as the number of women authors increase, indicating the number of women clinician investigators on the study team, there is more women patients enrolled in the trials. And we presented this at the American Heart Association. Well, this is one of our studies. We looked at AFib trials again, and there was few women in the trials and very few women on the leadership committee of the trials. But for every 1% increase in women authors of the trials, women in leadership of the trial, was associated with a 19% increase in women enrollment in the trials. So, conclusions here, again, women remain underrepresented both as participants and also as authors, as leaders of the trials, but they are correlated. And if we can improve our pipeline of getting women into cardiology, that might help reduce the disparities in both these areas. So that's it of some of the studies from the AHA. There certainly were a lot others, and I look forward to the question and answer session. Thank you.
Wonderful. Thank you so much, Dr. Mikos. All important and very valuable information, for sure. Before we get started on the questions from our audience, everyone right now is very focused on COVID. So what impact, I got a couple questions. What impact do you think both COVID and the resulting emotional stress have on heart disease?
Yeah, so as I mentioned, viral infections can trigger a heart attack. There's been studies that suggested that, after an influenza infection, there can be a six-fold increased risk of heart attacks. And we do see heart attacks and other kind of cardiac injury with COVID infection. We think that COVID can both cause a heart attack through overall stress of just being really, really sick, can stimulate a heart attack, or it may be that the virus can actually damage the heart directly. And so just like influenza vaccine, as I showed you and through our study, can reduce the risk of a heart attack, I'm hoping that getting over this pandemic and delivering the COVID vaccine that can help reduce heart attacks as well if we can treat COVID. In terms of mental health, we've all been under tremendous stress and duress from everything that all the grief and the loss and all the changes in our life that has been over during this pandemic. And certainly stress can directly impact heart attack rates too. When people are under low-grade stress, it activates the sympathetic nervous system, the flight or fight response. So when we're under stress, it raises our heart rate, it raises our blood pressure, it triggers the inflammatory cascade in our bodies. And so stress can directly trigger a heart attack as well. So we need to pay attention to our mental well-being, the well-being of our patients, our colleagues, our friends, people in our social networks, and individuals need to come up with healthy coping strategies during this pandemic. And certainly that may vary by individuals, but exercise, meditation, eating healthy, social connection. Just because we're socially distant doesn't mean that we have to be socially isolated. We have a lot of technology at our hands that we can stay connected. And so it's really important that we pay attention to our mental health because it really impacts our heart health.
Have you found that there's any research regarding the long-term or lingering impact of COVID on heart disease?
So, we're, not even a year into the pandemic. So we don't have, years and years and years of data. So it's a little bit, this is an evolving field. I think we're still trying to learn. We are seeing already some signs of what's being called a long COVID syndrome. So I've been seeing a lot of these patients in my clinic who, after a COVID infection, we're seeing a lot of something called postural orthostatic tachycardia syndrome, POTS. Patients are reporting a lot of fatigue and they're having this kind of elevated heart rate for kind of a long time after their infection, low blood pressures, dizziness with standing. We know that this virus infects the nervous system. We've heard about the loss of taste and smell, an increased risk of stroke, and it also may affect the nervous system, the autonomic nervous system that regulates the heart rate and blood pressure. So we are seeing patients with POTS syndrome, and so I have a lot of referrals for that. There's some question of whether COVID can cause a myocarditis and inflammation of the heart. This was looked at in athletes. I will say that, we're still trying to sort this out. There was one study that suggested that this was maybe a greater concern. And then another recent study suggested that prevalence was pretty low. So it's still a work in progress, but certainly I think if anything we can do to avoid COVID because of the potential, because we really don't know what the impacts are going to be down 5 years from 10 years from now, but everybody focuses on mortality or death rate. But, there's, people even who survive COVID can have lingering consequences for a long time, inflammation and scarring in their lungs. And this is why we need to do everything to prevent COVID, mask wearing, social distancing, vaccination. We're in a huge crisis right now.
And I would imagine also too, to make sure that our consumers continue to get their care, because it seems like a lot of people, are avoiding their actual care that they need to get annually.
Yes, I mean, it's really important that during this infectious pandemic that we don't ignore the pandemic of cardiometabolic diseases, of diabetes and cardiovascular disease, and that we still need to pay attention to cardiovascular prevention. As I mentioned, some of the patients that are at greatest risk for severe COVID are patients who have cardiovascular disease, obesity,
Sure.
diabetes. They're at risk for worse COVID complications. So we really need to try to optimize and try to prevent these conditions or treat these conditions for heart health and also for avoiding severe COVID.
Do you believe then that the COVID vaccine will have an impact on cardiovascular disease?
I do. I mean, we don't have the data yet. So I'm just extrapolating from like influenza and other things. But as I mentioned in my own research, we showed combining all these trials that the influenza vaccine can reduce heart attacks. That's because we know that viruses can trigger inflammation. They can trigger a plaque rupture in the heart arteries. And so if we prevent the virus, we can prevent the heart attacks. So I'm hoping that we will see a similar thing with COVID vaccine, but we don't have that data yet.
Okay, Erin, this is a question we're going to go to our viewers now. And this is a question from Barbara. Can taking too many calcium supplements increase a woman's risk for heart disease?
Yes, so hopefully you can hear me okay. I don't know why my screen is frozen, so I apologize for that. But this is an area of concern. In terms of going back to diet, dietary calcium through food sources has not been shown to be associated with increased risk. Strongly encouraged to try to get the calcium in through diet. We recommend for women over the age of 50 to take in 1,200 milligrams of calcium. So we try to get it through food sources. In terms of supplements, there are some studies, including my own work, that have shown that calcium supplements can increase the risk of a heart attack, especially large boluses. When you take a large dose all at once, it can transiently increase your blood levels of calcium, and that can potentially trigger clotting cascade. It also could maybe trigger calcium in the blood vessels. Now, we didn't see that with every study, but there's enough studies that show increased risk with calcium supplements. It makes me a little bit nervous. So my recommendation is to patients that they try to get as much of their calcium in through dietary, through food sources, and that if they do need to take a supplement, maybe not more than 500 milligrams at one time, because it's hard for the body to process more than 500 milligrams at a time. But to keep a food diary and try to see if you can get, because it's important to get enough calcium, but trying to see if you can get as much of it through food. And there's calcium beyond just dairy. I should mention that there's calcium in leafy green vegetables and almonds and figs. And so trying to get through white beans and edamame. So trying to get the calcium through food. And then if someone's at really high risk for bone disease, you can talk about the risk benefit ratio, but trying to minimize not taking a big bolus of 1,200 milligrams of calcium supplements all at once.
Sure. Thank you. This is a question from Karen. Forgive me if I mispronounce this, but is Vascepa effective in preventing MI in older adults who have had a heart attack?
Yes. So the study that I showed, that was the study that showed the benefit with the pure pure EPA, the 4 grams a day of pure EPA. Mm-hmm. That was icosapent ethyl is what's called Vascepa. So that was the one fish oil that showed the benefit. I told you about all the other studies that didn't show the benefit, but the fish oil, the Vascepa, was the one that did show benefit. And it was seen in all the different groups of patients in the trial that was in there. So it was seen both in the older adults and younger adults, people who had heart disease or just had diabetes and risk factors. So it does seem to benefit. And the question is why we couldn't see any benefit with prescription fish oil in that other trial, the strength trial. And that might be because that was EPA plus DHA. But the Vascepa trial is the one that showed the 25% reduction in major adverse cardiovascular events. And so that's why we are using it in adults who either have diabetes and other risk factors or established cardiovascular disease.
Sure. Thank you. We have a question from Liz. Is there a connection between statins and dementia?
So actually, statins seem to reduce the risk of dementia. So the association between statins and cognitive decline have actually been ruled out. That some of that initial concern came from sort of confounding by epidemiology studies that older adults take statins because they have heart disease, and older adults have, cognitive decline because they have vascular disease. But the things are actually not, they're associated, but they're not a cause and effect. But actually, in well-done studies, has kind of ruled out that statins, don't cause cognitive decline. And if anything, statins can decrease the risk of dementia, because a lot of dementia is due to vascular disease, vascular dementia, and statins reduce the risk of heart attacks and strokes. So statins actually may decrease dementia rather than cause dementia.
Interesting. Thank you. Dr. Mikos, this is from Ellen. She wants to know, do these studies include women of color as well as Caucasian women?
Yes, and it depends on the study how many of the women were, but minorities, women of color are very underrepresented in trials. So we need to do better. In one of the analyses I looked at for cardiometabolic drugs, we found, only 4% of trial participants were Black adults. And so they were very underrepresented relative to the represented US population. So this limits the efficacy, the knowledge we know about the efficacy and safety of these drugs. Sure. Some of these trials did a little better. The VITAL trial that I mentioned at the very beginning, the one that looked at vitamin D and fish oil, they had 20% of their participants, they had over 5,000 Blacks, which was 20% of the population. By design, they try to over-enroll Blacks. So some studies have done better at this, but most studies don't enroll enough minorities. And so it's another area of knowledge gap.
Thank you. This is a question from Mary. Does 100 to 200 milligrams, is it CoQ10, help support heart function? CoQ10 itself hasn't been shown to reduce the risk of heart attacks or anything like that. So we don't have a strong recommendation for it. Now, some patients swear by it. They think it really helps with muscle-related symptoms. The data for that is pretty weak, but a lot of patients swear by it. So I kind of think of it as relatively benign. If it can help my patients stay on their statin, I know they get the benefit from the statin. So sure. I don't discourage them if they want to take it, but I don't, recommend it if they're not already taking it, because there really isn't any strong data that it's any benefit. Right. Thank you. The next question is from Kath. And she says, some ophthalmologists prescribe fish oil to alleviate dry eye syndrome. Does this put heart health at risk?
So in most of these trials, the fish oil at the doses that were used, the 1 gram a day, that we didn't really see much of an excess risk. The risk for atrial fibrillation was risk with higher doses of the fish oil. It depends what kind of dose that they're using and which formulation. Again, I think it really matters the type of fish oil, and I'm not really aware how, good fish oil is at actually improving dry eyes, and whether there's other therapies that can be used in self. I'd love to chat with an ophthalmologist about that, but.
Sure. Thank you. Kind of switching gears, this is a question from Margarita, and she wants to know, is baby aspirin still recommended to prevent a heart attack?
So in patients who already have heart disease, if they've already had a heart attack, already had a stroke or a bypass or a stent, what we call secondary prevention, aspirin is strongly recommended for them. But in primary prevention, healthy individuals, we've gone away from that because there was 3 major trials that were published in 2018 that really didn't show a benefit of aspirin in healthy adults, but there was, an increased risk of bleeding. So there was increased risk of harm. And then especially in older adults, there was actually more deaths in the aspirin arm. So again, just because something is over the counter doesn't necessarily mean it's benign, and aspirin has some risk of bleeding. So we recommend it if someone's really at high risk for a heart attack, if they're at low risk for bleeding. But if they're at low risk for heart attack, we generally discourage it now.
Mm-hmm. Thank you. This is a question from Anita. It says studies again illustrate that the supplements, your studies are showing that the supplements are ineffective of preventing cardiovascular disease. So what does work?
So preventing cardiovascular disease. So the most important way to prevent cardiovascular disease is a healthy lifestyle throughout the lifespan. So eating well, balanced diets rich of fruits, vegetables, whole grain, fish, getting regular exercise, 150 minutes a week of moderate intensity exercise, at least 30 minutes a day, maintaining a normal weight, not smoking, maintaining a normal blood pressure, normal blood glucose, and normal blood cholesterol is all very important. And as I mentioned, if someone is at high risk, despite these changes, these lifestyle changes, then the first line therapy is statins. That goes back to the Samson trial. So we have overwhelming evidence of the benefit of statins. That's why that's still first line. Sure. Now, many patients who are on a statin still have elevated risk, and there's additional drugs that sometimes we use that we add on top of a statin to try to get the cholesterol even lower. So in very high-risk patients who have genetic elevated cholesterol, familial hypercholesterolemia, we've been using new medicines called PCSK9 inhibitors. So those are usually all added onto a statin. So statin is the first line. If someone is at high risk, if someone is at low risk, we encourage lifestyle as the foundation.
Sure. Yeah, it seems to be the pretty common answer is lifestyle. Dr. Mikos, Meredith has a question. Should women in their 70s with cardiovascular risk take a statin?
Yes. So I wouldn't have them take an aspirin unless they already have cardiovascular disease, but there is quite a lot of data suggesting that statins benefit older adults too. Older adults is a heterogeneous group. So not every older adult is the same. So many older adults are very healthy and have a pretty good life expectancy. And so we would if somebody has, 5 to 10 years good life expectancy, we would definitely recommend a statin in them. On the other hand, if an older patient is frail, has multiple morbidities, in a nursing home, has other serious health issues, then they're likely not to derive benefit from statins. But in healthy older adults who have cardiovascular risk, yes. In fact, there's been 2 studies that suggest that older adults who stop their statin are at increased risk of heart attacks. So we don't recommend stopping unless there's another compelling reason to.
Sure. In our closing question, Dr. Mikos, quickly here, we hear that women, they fear that they're having a heart attack or not taken seriously by emergency personnel. So how should patients advocate for themselves? I think that's a really great question.
Yes, unfortunately, there are delays both, on the patient side and the provider side of women getting timely care in the setting of a heart attack. So on the patient side, women often stay at home longer with their symptoms. They're more likely to attribute their symptoms to something else. Think that, I'm a woman, I can't be possibly having a heart attack. This is probably anxiety. This is probably indigestion. So they're, take longer to get to the emergency room. And often they drive themselves instead of calling 911 like they should. But then when they arrive to the emergency room, there's data suggesting that clinicians are not recognizing or treating them as appropriate either. And so there's delays on the physician side, and we're certainly working with educating our clinicians. But I think that, women should, certainly be very clear about their symptoms, that this is not their baseline, that something is wrong, and explain their symptoms and not diminish it or worry that they're bothering anybody, but really advocate that, that this is new for them and that this should be taken seriously.
Very good. It sounds like be proactive.
Yes. And then everybody should just get their risk screen, make sure that they, get
That's
all
right.
the risk factor screen.
Well, Dr. Mikos, thank you so much. It looks like we've run out of time, and I want to thank you again very much for your time this evening and for all of you for joining us as well. Dr. Mikos has graciously agreed to try to respond to any unanswered questions you may have had, and we'll email them to you. If you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Women's Journey, to watch for announcements about future conversations, podcasts, and special programs brought to you by A Women's Journey. In the meantime, we hope you will find our monthly email informative and engaging. Conversations That Matter is brought to you in part through a non-restrictive educational grant from Bristol Myers Squibb. Have a good evening and stay well.
Thank you and good night.
Thank you very much.